This conference will now be recorded.
Okay, we will start now. Just I will share the screen. Just see whether you are able to see the screen or not. 1 minute. Okay, are you able to see the screen? All of you?
Yes, yes.
Yes. Okay. Okay. So yes, yesterday there was Dr. Jyoti's session, and it was actually it was a very good session. And I will tell that transgender session. It was very this thing. It was what I will tell. She acted so beautifully yesterday. Okay, but yes, she discussed yesterday where, all like difficult station like negotiation and how to handle difficult patient and all this. So I thought today I will take more about structure discussions, because now the exam is in equal parts. It contains almost 7 structure discussions and 7 SPTs. So teaching are included in the structure discussion. I consider teaching also as a structure discussion, because we have to approach to the teaching station as a structured only, because we have to give information in the structured way, and we should know all the theoretical part while we are approaching any teaching station. Okay, so there are now 7 structured discussions in the exam, so I think we should also concentrate on that part of exam also. And we should know something regarding the theory. Now it's not that only counseling will help you to pass the exam. Now you should know some things about guidelines and top articles also. Okay, so yes, now so whenever you're going to remember well this exam, whenever you are approaching this exam, your attitude should be like this: I'm not here to be average, but I'm here to be awesome. So whatever is the level of your preparation, you should go with this attitude. Okay, and you should be confident. Then I think you can handle this exam very well. Okay, because everyone is prepared, but this attitude, if it is there, then it will definitely help you to pass the exam. Okay, so now this structure discussion, when we see this structure discussion, we can divide them into this broad categories. Like you can get something like data interpretation, in which you will get some graphs or some investigations that you have to interpret and come to some conclusion and give the management plan, like any urodynamic studies, CTGs, blood investigations. So all these things, data interpretation, we have to do either, or we have to describe any procedures. Okay, any obstetric procedures or any gynec procedures like laparoscopy, cystoscopy, hysteroscopy. These things will come as a structure discussion. Then there will be either prioritization, labor room prioritization, theater list prioritization, or ward rounds like preoperative and post-operative ward rounds. Then there can be discussion regarding the emergencies, either obstetric or gynec emergencies like eclampsia or uterine inversion, EPH. So all these things can be there, or it can be evolving structure discussion. That means you will get first some information regarding the patient, and as the consultant, the examiner will be asking you the questions, and in that he will provide you some investigation, he will provide you some ultrasound reports, MRI reports, and depending upon that he is going to ask you the further questions. So these are the different types of structure discussions that you will get. So today we are going to do 3 structure. Today we are going to do 4 cases today. 3 we will do structure discussions, and 1 I will do 1 SPT with you. So sorry, anyone who is volunteer for the first station?
Can I?
Can I do, doctor?
Who has done yesterday? They are not allowed, please. Who has done yesterday? They are not allowed. You are not there? Who is this?
Yeah,
1 minute. Who is this? Nafisa.
I'm Dr. Nafisa. Yeah.
Okay, yeah, Nafisa. Okay, okay, you can do. No problem. So 1 minute. Yeah. So this is your first slide. You just tell me whenever you want to move on to the next. Okay. There are 3-4 slides. I will start your 2 minutes.
Dr. Mrudula asked Dr. Vigana to close the video, please.
Whose video is on? 1 minute,
Dr.
because
Vigana.
Rehana, Dr. Rehana, please close your video. Yes, please close your video. You can, all of you can see the screen. The screen is visible.
Yes, doctor.
Yeah. Okay. So yes. So this is your first slide. I am going to start your 2 minutes now. Okay. Whenever you want to move on, just
Yeah,
please
next
next. Okay.
next
Fine.
slide, doctor.
Okay. Okay. Sure.
Mm.
Yeah.
Next slide. Next.
Next slide you want?
Yeah, this
Next
one.
to this? This one, no?
No,
Yeah.
no.
Okay.
This one.
Okay.
The next one, doctor.
Next one is about the question. So I will ask you the question. Don't worry regarding that. Okay. If you want, I can give you the questions ahead. No problem. There are total 6 questions, but I will ask you the question as in you go on. Okay. So concentrate on this slide only, I think.
I'm ready.
Okay. Let your 2 minutes get finished. I will start with after 2 minutes. Okay.
Okay.
See, because you can't enter the cubicle before 2 minutes. Yes, your time is up. You can start.
Hello, I'm Dr. Nafisa, and I'm ready for the structured discussion.
Hello, doctor. So as you have seen this graph, so can you tell me what exactly it is?
It is a maternity dashboard.
Okay,
It is
and
one of
what?
the it is a
Yes.
one of the indicator of a clinical it is a one of the indicator of clinical governance tool, or a clinical tool of a clinical governance.
Okay. What are its uses?
There are benefits. Actually, they are associated with some benefits with it. In this, usually,
Uses.
what it is, yeah, it is actually a visual display tool which we use to assess the clinical performance of any maternity unit compared with that of a standard. In this, we will come to know how much we are close to the standards. Depending upon the colors which have been demonstrated here, like green, amber, and red. By this, we will come to know whether our goals are met or not met, or we have breached those goals. And it is one of the indicator to improve our practices if anything has gone beyond our it's been breached. It can be returned back. Should I explain in detail what does everything mean? What does
No, I will
green
ask
mean?
you.
All this.
No, I will ask you. So yes. So what is the salient features of this maternity dashboard?
Yeah, the salient features are there are some parameters which we usually monitor in this one. One is the clinical activity, workforce, clinical outcome and the patient satisfaction. In the clinical activity, usually we will look either in the consultant, it is once again, it is in a consultant-led care or the patient or the midwifery-led care. Usually in the midwifery-led care, number of the home deliveries, number of water births, or number of referrals to that consultant-led or taken care or just studied. And whereas in the consultant-led care, number of antenatal cases, admins, how many antenatal cases coming, how many deliveries happening, how many CS happening, how many instrumental deliveries happening. These are the things which were seen in clinical activity. Now coming to the workforce. In the workforce, usually we will look for sickness leaves and sickness leaves, bank staff, and then like how many hours of consultant presence is there. These are some of the things which we usually look for in the workforce. And the next is the clinical outcomes. In these clinical outcomes, we look for some incidents like undue incidents like a shoulder dystocia, Erb's palsy, postpartum hemorrhage, need for blood transfusion, or any failed instrumental deliveries, or any third degree and fourth degree. These are some of the things which we usually look for in this one. And then the next will be that these are some of the this one, and the last will be the patient safety issues, like whether the patient is satisfied with our care or not. Is there any complaints or any incident reports being raised? All these things we'll usually come to know.
Okay. So what are these advantages and disadvantages?
Advantages is as I have been, it is usually, it will help you to improve the quality of the work performance. As a result of it, the improvement in the patient safety is there. And then advantages, that's what it will improve the quality of the care. At the end, it improves the quality of the care. And the disadvantages are it needs a lot of work to be done, all this data has to be collected. You may need some statistician, some IT help you may need, and data collection takes your time. And sometimes sometimes it will be just a paperwork, but only that it is a graph present but no implementation being done. These are some of the disadvantages of this one.
Okay. So when these indicators are shown in this graph, whether they are static or you can change it.
Yeah, it is not
The
static.
parameters you are. Yes.
Yeah, parameters can be changed. For example, if any incident is, if you think any incident is happening in your unit every time, then we can usually that parameter is to be selected, and then we have to, with the same thing, we have to compare with the standard. What is the standard for that parameter? Are we up to that, or we are breaching that one? If such is the thing, we can make it, we can change some of the parameters if we want, like for example preterm births, or instrumental deliveries, or increased CS are there. Some of the parameters can be added to it.
So now can you comment on this failed instrumental deliveries in this graph? In this
Yeah,
dashboard?
I will come to it.
Yes, can you comment on that?
Yeah, I'm just going through this one.
Okay.
Sorry. I have not. Failed instrumental deliveries. If you see the failed instrumental delivery, the goal which should be less than 1%. Okay, if anything is within the less than 1%, it is considered to be normal. And the red flag which is more than 3%. For example, if the instrumental deliveries are crossing more than 3 out of 100, if there are more than 3 they are crossing out of 100, then means you are breaching that standard. So when we come when monitoring the months here, all these instrumental deliveries, failed instrumental deliveries, it's a failed instrumental is less than 1 is acceptable. Like out of 100, 1 is gone wrong, which has gone failed, and you have gone for CS is acceptable. Whereas more than 3 in 100 in a month is not acceptable. Okay, in the first is in the all the months. 1 minute, because the screen I'm adjusting, it's going.
No, actually, months have not given there. Yes, you can just comment on
Okay,
this.
in the fourth one, when you see it is an amber color, might be Jan, Feb, March, April. If you think it has crossed 1.2, but it is still within less than 1 and more than 3. It is between both this one. It means it is in the amber range. That is it is in between the range. If it is there in between, just usually if it is not much high, we can just observe it over a period of the time. Okay, if the over a period of the time, if it is getting adjusted by itself, no need to take action. If the same element is going into amber line for a couple of months, then definitely some action should be taken, and we have to inform it to the local trust also regarding that. But any time any event or any of the element has gone into the red line, that means it has breached the goal. Then definitely an action has to be taken. For amber, it depends. First, for anything has gone into amber, see whether the patient safety is ensured or not. If patient safety is there, then we can wait for a couple of 1 or 2 months. If it has gone back to green, well and good. If it's continuing in a 2 or 3 months, it's going to amber, then definitely an action has to be taken and inform the local trust to take some necessary action against it.
Okay. So what can you think this causes of this failed instrumental delivery that is going in amber color? What can be the causes of this, and how you can rectify if it becomes pigment amber?
Yeah, the one of the causes might be lack of training from the staff. Might be they're not well trained in doing that, or might be the consultant was not present. If there was some difficulty, for example, if it is a high forceps or mid cavity forceps, might be it would not be happened with a trainee, but a consultant would have been done it in a better way. So consultant presence, whether consultant presence is there or not, training is up to date or not. And that's all. These are some of the things which
And
can
how
be
you can rectify
brought up.
it? How you can rectify it if it becomes
I
frequent
can
amber?
frequent ever, I have to do an audit for it. I have to see what are the factors which are contributing to it. I will see whether it is a lack of the training. How is the training going on every yearly? Actually, this instrumental deliveries, any training or workshops are being run or not? Is there active participation of the trainees or colleagues in that? And also for the consultant presence, like how many hours the consultant is available in the hospitals. We can increase whether in the night times, especially the consultant availability is there or not, so that we can help it, so that in that way we can see and we can rectify some of the things, so that patient safety is not breached.
Okay, almost time is up. It is 1 second only. Yeah, my questions are finished. Okay.
Okay.
Okay, so thank you.
Thank you, doctor.
Yeah. Okay,
Shall
so
I mute myself for doctor? Shall I?
Yeah,
Okay.
just tell regarding your performance, and then we will discuss it. What do you think?
Actually, this maternity board, what I studied maternity board was different, and this looks totally different. But the concepts are the same, because it's only an indicator by which we have to be safeguard. We have to be careful enough. Like something is going beyond the green, we have to be careful. But if not, I feel even though the dashboard may vary from hospital to hospital, but the implementation, the principles are the same.
Yes.
So I gone ahead with the same.
Very good. Yes, actually you did it quite well. Okay. So you
Okay.
were knowing the basic concept of this maternity dashboard, and yes, you were knowing how to read it. What are the exact, what are these indicators, and what are the parameters you will be seeing in this maternity dashboard. So actually, it was a registration for you. So you did it well, quite well, no problem at all. Okay. There are some things just only in salient features when you tell regarding these indicators, green, red, and amber. So you have to tell that uses also. So what does red means to you? So what if red parameters, what if the parameters are in red indicator, what action you have to take? Okay. What if it in amber? Okay. And who should fill the this maternity dashboard, and what are the standards? Okay. So these are the some things that
You
was
should,
expected.
yeah, it is a clinical lead manager will be there, lead clinic midwife will be there, and a lead consultant are there who will be involved in this. Actually, I thought that comes as a question, so I didn't get to you that.
Okay, okay. So
Mm,
actually, it was a
okay.
broad question, salient features thought that I asked you. Okay.
Oh,
So
okay. Okay.
yeah.
I'll mute
So
myself.
yeah. Okay, no problem. Yes. So this the proforma is, yes, it is a maternity dashboard. So please be well versed with this proforma maternity dashboard. Exactly what indicators. Most of the time the indicators will be similar, okay, but you will not get the same maternity dashboard in the exam. There are different. It will be different for each hospital, okay, and it will be different for hospital. Like every year, it will be different because some indicators will be made and they will be removed from that dashboard, and another indicators will be added because it is not static one, it is a dynamic one. So definitely you are going to get different types of dashboard. It is not that you will get a same dashboard and the same parameters will be in red or amber. It will be not like that. So you have to analyze that dashboard and give your opinions, okay. So definitely the first 2-3 questions will be generalized regarding the generalized dashboard, and then 1 or 2 questions in that structured discussion will be regarding that specific dashboard, and they will ask regarding any of the red or amber parameters, and they will ask exactly what can be the causes of this or what can be the how you can rectify these causes. Okay, so this will be the usual questions in this maternity dashboard. So see the definition should be like you should know some definitions. It comes maternity dashboard definitions comes in that. So this is a clinical governance indicator. Okay, so this maternity dashboard is a clinical performance and governance indicator which help to monitor this performance against set standards or goals. And how it will help? It will help to safeguard good clinical practice, and it will help to improve the outcomes. Okay, and uses are, it is used to benchmark the activity and monitor the performance against set standards. Okay, and it is usually done on monthly basis. And see what is this green, amber and red. So these green indicators, when the goals are made, it will come under, they will be, the standards will be set, and these standards usually will be taken by either with the help of guidelines or local trust standards. Okay, the standards will be decided by either local trust or it will be taken with the help of national guidelines. And then there will be these indicators. So where there will be green indicators when the goals are made, so you need not take any action regarding those greens. Ambers, the goals are not made here, but still they are above lower threshold, so it requires closer scrutiny. Okay, and if the ambers become frequent in that dashboard, then we should take necessary action that it should not go in the red zone. Okay, now, red is when that upper threshold is breached. So, in that case, urgent action is required, or otherwise it will cause serious harm to the patient's safety. Okay, it will pose a serious threat to the patient safety. So, for any red indicator, urgent action has to be taken. Okay, so this action, it is either at individual level, it is at the hospital level, that is institutional level, and it will be at the trust or college level. Okay, depending upon the indicators. So now what indicators, as she told, Nafisa told very correctly. So there are broadly 4 categories: clinical activity indicators, workforce related indicators, clinical outcome related indicators, and patient satisfactory survey or risk related. So clinical activity related indicators are, yes, it is number of antenatal bookings, cesarean section rate, number of instrumental deliveries. So it is the whole statistics usually. So for clinical activity, usually the statistics of your labor room, okay, or your maternity ward. Then workforce related means what is the midwife to delivery ratio, or what is the consultant to the workforce. Okay, so number of the workforce, sickness leave, training days. Okay, so it will see whether you are having a overloaded. Okay, so workload is very high. So in that case, definitely the mistakes are going to happen if the workload is very high. So that, and remember that most of the time this will be the reason for any reds or ambers. Okay, in any maternity dashboard, if you see red and ambers, you have to see when your targets have reached and they are more than the green. Okay, so like your target for antenatal booking, if it has crossed beyond that threshold, that means you have overload. Okay, you have overload. If number of deliveries are more than your target, then you are overload. So that means the mistakes are going to happen, and most of the time the reason in that ambers or red will be the workload related. Okay. And then clinical outcome here, most of the time complications are measured, like eclampsia, major PPH, massive blood transfusion, third, fourth degree tear, and fetal related complication like any preterm births, stillbirths. Okay. So brachial plexus injury, failed instrumental delivery. So all these things, these are comes under clinical outcome. And then risk incident and patient satisfactory survey. So this includes usually the how many complaints have been lodged, what was the patient feedback, what was the attitude of the staff. Okay, so all these things comes under anything related to communication and the performance. It will come in the risk incident or patient satisfactory survey. And always remember that this is a question which is usually asked regarding this maternity board, maternity dashboard is. So these parameters should be always dynamic. They are not static. They are not fixed parameters. Once compliance of one parameter is achieved and monitored for some time, then it should be removed. Like if it has come, if something was in amber, once it has come under green for some time, then it should be removed and new one should be added. Okay. And national, local or evidence-based guidelines should be used to set the standards, okay, to set these goals. So for this, as I told you, national guidelines or local trust guidelines should be used. Who will fill this dashboard? So who has a clinical risk perspective? Okay, who has clinical risk perspective, like any risk manager, midwife working closely with lead consultant. So who has any experience in that risk management, they will fill this dashboard. And it should be widely distributed to the all team members, like all midwives, trainees, consultants. So they can have a analysis of it. Advantages, remember now these advantages and disadvantages, very remember this very well, because in structure discussion you have to talk very specifically. So, like Nafisa, she was knowing everything, but then when it came to advantages, she couldn't tell much. Okay, so remember these things. Key, you have to talk very specifically regarding instructor discussion. So, advantages of maternity dashboard is, so it helps to identify and promote areas of good clinical practice. So, all three indicators you have to talk about in advantages. So it will promote good clinical practice. It will help to detect and rectify areas that need improvement. That means amber. Okay. So it will help to detect areas that need improvement, and it will also help to identify what are the unsafe clinical practices going in that maternity ward. Okay. So any red means there is a threat to the patient safety. So it helps to identify these threats. Okay, or any unsafe clinical practices. Now, what are the disadvantages? So yes, if you just fill this maternity dashboard mechanically, then it will become only another paper exercise. Okay. So to avoid this, we have to see that this maternity dashboard indicators, they suit this local needs. The indicators which are included, they should suit this local needs. It is not the universally accepted indicators. So what do you think? What you think that in your maternity ward some complications are happening very frequently? So those indicators you should include in the maternity dashboard, and these parameters should be changed periodically. Okay. So to avoid this as another paper exercise. Okay. So clear regarding this maternity dashboard. Now, when I ask regarding this failure of instrumental deliveries, so see, this is the graph. So can you see here this failed instrumental delivery? The green category is under less than 1%. And the red zone is more than 3%. So between 1 to 3% becomes the amber zone. So when this failed instrument is less than 1%, they are acceptable. If it is more than 3%, so it becomes unsafe practice. Now you have got only one amber in this. Okay, so only one amber, that means okay, it can be because of some heavy workload, or sometimes it is because of some new trainees arrives. Okay, whenever there is new trainees arrives or new consultant arrive, in that cases such things may happen. Okay, if it is like a single month or something like that. But if it becomes frequent umber, that means you have to evaluate it, you have to analyze its causes. And then causes can be, yes, first is the lack of proper assessment. Okay, so whether she is fit for instrumental delivery or not, you have to assess that first. So lack of assessment can be there. There can be either these prerequisites are not properly followed for these instrumental deliveries, lack of training, as Nafisa told, lack of training can be there, or consultant is not available, so lack of supervision. So these can be the reasons for this failed instrument delivery. How you are going to rectify it is, so whenever anything you are telling regarding how to rectify, so you have to tell at the individual and institutional level, and you have to tell at the trust or college level. Okay, so at individual or at institutional level, how you can rectify these mistakes is, first is like you have to see that proper selection of cases is done. Okay, for any instrumental delivery, proper selection is done. Okay, the indications they are verified, and for that consultant, so involvement of senior obstetrician or consultant. Okay, so while decision making should be seen by or done by consultant if you are getting any frequent umbers or reds. Okay, so that means you are not selecting any improper cases for this instrumental delivery. Then also at institutional level, you have to see that the deliveries are supervised. These instrumental deliveries are supervised directly by the consultant. Okay, if you're getting these frequent embers, then also you can improve your training at the institutional level only. Okay, like in trainees. Training of this trainees you can improve at institutional level, and even at trust level also, providing training on the simulators. So providing training and the simulators, also arranging training programs very frequently for newly arrived trainees, and also assessing competency before allowing them to practice instrumental deliveries independently. Okay, so this competency assessment should be strict. So these are the things how you can rectify these failed instrumental deliveries. Okay, so clear regarding this maternity dashboard? Any doubts?
Hello,
Yes, yes,
ma'am.
Dipti.
In the dashboard, what is that number of SUIs?
Actually, this SUI, I don't know. Actually, SUIs usually, I don't think I have not seen any SUIs in the maternity dashboard previously. This one, I don't know. Okay, it might be related to any forceps or this thing, but I don't know exactly what is this SUIs in this dashboard. Okay.
Okay, okay, ma'am.
Yeah, because I think SUIs, I have till now, I have not seen any SUIs in any dashboards. Okay. So it is, yeah, and it is related to prenatal. So it related to anything, something like fetal, correct? But I don't know what is this. Okay.
Yes, ma'am. I have one question, please. How
Yes.
many numbers how many numbers should be there in this board so that we know we have to take some action?
How many numbers, they have not given any standards that it should be 2 or 3 or something like that. But if you get frequent numbers, so that means anything more than 1, it will be frequent numbers. If you are getting any consecutive numbers, then it should be a point of worry and you should start taking actions. Okay.
Okay. Thank you.
Yeah.
Hello.
Yes, any questions?
Yeah. Ma'am, you said rectification would be on individual level and trust level.
Yeah.
So what would be the what all rectification would be there at trust level here?
See, here at individual level, individual or hospital, institutional level, means that maternity ward. Okay. At that level, what you can do is, first you can see that involvement of senior obstetrician is there in the decision. Okay, like in selection of cases. Okay, proper selection of cases has been done. Okay, and it should be directly supervised. That you can do at this hospital level, correct? At that maternity ward level. Okay,
Okay.
and at trust level, you have to see for the a broad aspect like providing training like simulator based training. Then you have to adhere to the strict competency level before allowing them to practice individually. Okay. So these are the things that you can monitor at the trust level or college level.
Okay. And ma'am,
Okay.
probably does SUI stand for serious untoward incidents?
Might be. Yes.
Okay.
Yes.
Thank you.
Okay. Yes. Someone has written. Yeah. Now it is Siri. Okay. Okay. So, okay. Is it clear or shall we move on to the next? Okay. So, yes, who is going to do next? Who will be doing next? Any volunteer?
Can I do Dr. Mrudula? Hi, Dr. Mrudula.
Nasima. Okay, I got someone think Nasima. Nasima? Is it Nasima?
Hello?
No, I'm Salma.
Nesma. Nesma or Nasima? What is it?
Yes, Nasma.
Nasma. Okay. Okay, you want to do?
Okay, thank you.
Okay. 1 minute. Okay, this is your station. I will start your 2 minutes.
Okay.
You can just tell me whenever you want to go to the next slide, okay?
Okay, so next.
Okay. This is the last slide.
Okay.
Yes, your time is up. You can start.
Okay, hello. I'm ready for the discussion. So,
Okay, doctor. So, as you have seen the scenario, you can, you are a doctor in the post-operative ward. So you have to tell regarding each patient's management. You can go on.
okay. So regarding the cases, I will go for Mrs. D. I will introduce myself and my role. I will take permission to go through the notes. I will see what was the gestational age she had termination for. I will, after her consent, I will examine her see if there is any pain, abdominal pain. I will also see about the amount of the bleeding. She needs her blood pressure is low. She needs resuscitation. I will call for help. I will tell the consultant. She had termination of pregnancy, so there might be suspected complication from maybe a uterine perforation. So I will tell her if she is conscious. I will tell her, and meanwhile I will also go for resuscitation by giving her IV fluids, and I will give her oxygen. I will also take her consent regarding a blood transfusion if she has any objection to blood transfusion. I will go for taking, I will tell my assistant to take labs to see about the hemoglobin, and also cross-matching and group and save, and will tell her after her consent to go to the theater because may need repair, and I will go for a WHO checklist and stabilize the patient, and can go for laparotomy if needed to repair, and then if everything is well regarding the operation, we will give after that antibiotic, and will document and debrief the patient and the team, and do incident report, and I will also she may need monitoring in the high dependency unit, and assessment for the thromboprophylaxis if needed, and the monitoring of the vitals and urine output. This is regarding for sick case. For regarding Mrs. A, I will go and also take a brief history and introduce myself, and she has breathlessness. I should resuscitate and give her oxygen, and I will examine her after her consent to see if there is any swelling in her leg or any problem, redness. She might be developed DVT. Now she has complaint, may have pulmonary embolism. I will order a chest X-ray. And if there is swelling, I will go for a compression ultrasound and Doppler, and I will give her low molecular weight heparin therapeutic dose, after also informing the consultant. And I will involve hematologist with this decision. This is regarding Mrs. A. Regarding, I will also tell her about the discharge, that she developed a complication and need more monitoring, and I will tell her that she will delay the discharge till she is stabilized and may need thromboprophylaxis and more monitoring. Regarding Mrs. C, Mrs. B, also she had laparoscopic sterilization. She has severe pain and swelling. So I will introduce myself and examine her, and her vitals is now good, but it may be bleeding. I will assess if she is taking any anticoagulant or any problem. I will examine, see if there is any pain. Also, I will go through the notes to see if there were any adhesion. And also regarding the end of the operation, if there was hemostasis and it was who operate look at the port side, it may be injury of any vessel, maybe maybe bleeding. I will tell her about the finding and involve the consultant, and using the SPAR tool, I will tell him about my examination and assessment and recommendation. I will also take labs, and I will then see if we can need to go back to the theater to see if there is any bleeding, or maybe do bedside ultrasound to see if there is any collection inside. Also, this is regarding Mrs. B. I will take her consent also and see about the blood transfusion. If she has any rejection to blood transfusion, may need cross-matching and group and save. This is regarding Mrs. B. Last is Mrs. C. She is now having a fever and right loin pain. So I will introduce myself and examine if there is tummy pain. What was also the urine output regarding here, if there was any problem. She has caster or caster removed. Also, I will go through the notes after her permission to see what happened during the operation. Was any, she has endometriosis, maybe excessive adhesions. This may lead to injury and maybe ureteric injury. So I will involve also the consultant or the surgeon, and I will give her, if she has pain, I will also give her analgesia, and I will I will involve the consultant. I will also see for imaging to see about the ureteric injury, and I will tell her that she may need surgery, and I will take the consent and for the surgery, and also maybe other than ureter, maybe injury in the bladder or any other problem. Also, we'll take labs. Maybe there is any fever. I will also see about the IV fluids, if she was taking enough hydration. Also, she will be debriefed, and maybe she has also sepsis. Will also look for the CBC and white blood cells, and give her. She also needs antibiotic after exclusion of any
Time
allergy.
up, Nesma. Time up.
Okay.
Yes. So whenever your time is up, yes, please always tell to the examiner that thank you for your time, and then get up from. I know we are under so much of tension, and if time gets up, we just get up from the chair and we just leave But no, we should not do like that. We have to always tell and keep this habit while practicing with your study partner also. Okay, so whenever any structure discussion is over, always tell thank you for your time. Okay, and then only leave the station. Okay. So please make it
Okay.
habit. Otherwise, we are not going to make it. We can't do it in the exam, okay, right away. Okay, there we can't do it unless we have that habit. So always, whenever you are practicing with your study partner, please make it a habit that yes, I will always tell whatever is the time. Once the 10 minutes are over, I will tell yes, thank you for your time and get up from the chair. Okay.
Okay.
Now, this is a post-operative round, correct? This is post-operative round. And Nesma, do you find any word here as it is a prioritization?
No. No.
There is no prioritization. Okay.
Okay.
You have to
Okay.
go case by case and you have to just tell what is your diagnosis and what is your management. Okay. And remember that the diagnosis is not always a final diagnosis. Here in any post-operative complication, whenever we see also clinically, it is a differential diagnosis, correct? Unless we do some definitive test, we can't tell that yes, it is a confirmed diagnosis just from the vitals and her complaints. So we can't tell any confirmed diagnosis, correct? We have to give the differential diagnosis and then we have to confirm it by doing some certain tests, correct? Okay, so always try to give the
Yes.
differential diagnosis whenever you examine the patient, and from history and examination only we can give is what we can give is the differential diagnosis. Okay, it will not be a confirmed diagnosis. Okay, and another thing is whenever you are going to summarize this case, always do it in the S-bar format. Okay, always do in any pre-operative round, post-operative round, labor ward prioritization, theater list prioritization. Remember, you have to summarize that case as a S-bar in S-bar format. Okay. Otherwise,
Okay.
yes, Nesma, what you did, yes, your diagnosis most of the time was correct only, but yes, you can't go with only one diagnosis. Okay, you have to confirm it by investigation. And another thing, what I like is, yes, you always told that yes, I will go to the patient, I will introduce myself. So that should be the first thing that you are going to do in the post-operative or anything in any pre-operative ward round, any labor ward. Okay, whenever you are going to the patient, you have to first introduce yourself. Okay, so I will first introduce myself to the patient. Now here the next thing will be always remember, always and always remember, if she is having any complaints, okay, like any pain, you have to give her analgesics. You have to see whether she has received analgesics, okay, whether she has received analgesia or painkillers, and whether she is comfortable to talk with you. Okay,
Okay.
so always offer her analgesia. Okay, and now in case of breathlessness, always offer her oxygen. If she requires resuscitation, first do that. First tell that. Do that means first tell that. Okay, and then go to your other management plan. Okay, so always offer any analgesia, any oxygen. Okay, any resuscitation required. Okay, and then go to the further part of that case. Okay. Now, next thing what you are going to do after offering this thing is, yes, you will take a targeted history if the patient is in the position to give that history. Okay. So see, I'm talking generally about any ward round. I'm not talking particularly about these 4 cases. I will come to that later. Okay. So I'm talking generally, if you get any post-operative ward round, okay, so or any this thing, labor ward for that matter, okay. So what you are going to do is always first you are going to start with the initial management, initial like any analgesia, any resuscitation, okay. Then what you are going to do is next thing is take targeted history, okay. You are going to take targeted history. Then you will definitely review her news charts, okay. You will review her operative notes. So all these things will come under information gathering. See, can you see here the domain is there, information gathering. Okay, so you have to do that. Okay, after that you are going to examine her. Then you will be giving some differential diagnosis, and then you will do some investigations, okay, pertaining to that case. And you are going to tell management plan depending upon those investigations. Always involve here, only in one case you involve urologist. Otherwise, where is your consultant? Where are your operative ward nurse? Where is your theater coordinator? Where is anesthetist? Correct? Communication with colleagues is a
Yes.
domain. If you don't involve that, you are going to fail in that domain. Okay? Correct? And this is such a simple sentence that you have to tell, and you are going to get full marks of that domain. Correct?
Okay.
All other domains, you have to tell so many things regarding each patient. Okay, like for patient safety or applied clinical knowledge, you have to tell so many specific things. But for communication with colleagues, you have to utter only this word, that MDT. Okay, so that you are going to involve your consultant, you are going to involve anesthetist, you are going to involve the post-operative ward nurse, any specialist like intensivist or neurosurgeon. Okay, so in that, and then anesthetist. So this is the simple sentence. It is going to give you full marks for that domain. So never forget this MDT. Okay, in any of
Okay.
these stations. So always remember that MDT. Now, once you tell the management, so in management plan, once you tell regarding the initial management, always remember, see, in the post-operative ward, there will be definitely one or two patients who are having some complications. Okay, that's why they have given that station. Okay, and whenever any complication means, the clinical governance part will arise. Okay. So
Yes.
whenever you
Okay.
are going to tell the management, you have to divide it between clinical management and clinical governance. Okay. So you have to tell that clinical governance part separately, so that the examiner, it is easy for you to remember also, and it is easy for examiner also to mark you for that. Okay. If you tell in between your clinical management, if you just utter one or two sentences that I will debrief her and this thing, so yeah, the examiner will be also confused whether you have told this point or not. Okay, so it is better that in clinical governance wise, I will debrief this patient and the family. I will file incident report if it is required. Okay, then I will I will perform the duty of candor. So these are the buzzwords, correct? These are the keywords that you have to use in such stations. So I will perform my
Yes.
duty of candor. Then I will again I will do the reflective practice. I will obtain feedback from my seniors, and I will reflect this in my e-portfolio. So this all comes under the clinical governance part, right? So these 4 or 5 points in clinical governance part, whenever there is any major complications, you have to utter these 4 or 5 points. Okay. And definitely in your post-operative ward round, there will be something that will be a major complication, and in that case you have to use these words. Okay, got it?
Yes. Thank you.
So yeah, so this is regarding any generalized, whatever I was talking till now, it was generalized regarding any ward rounds. Okay, any post-operative rounds. Okay, repeat 5 points of clinical governance. So yes, so clinical governance first start with debriefing. Okay, debriefing the patient and the family, and also your staff. Okay, so that will be the first part. Then you will perform the duty of candor. Okay, then third thing what you will do is incident report if it is required for that case. Okay, then after that you will see if any further action like root cause analysis, but it is not under your point. Then the risk manager will decide that whether to do it or not, audit or root cause analysis. So incident report. After that you will you will do the reflective practice and obtain feedback from your consultant or your seniors. And the last thing is you will reflect in this your e-portfolio. Okay, clear? Medha or Megha, 1 minute. Clear? Megha.
Yes, ma'am. Yes,
Yeah.
ma'am. Clear. Thank you.
Okay. Okay. Yes. So now when now we hear whenever we will go case wise, so what will come? So always make it a habit that you present that case in any SBAR, in any case in such patients in the SBAR format. So how you're going to do the first case here? So this is a day 3 post-operative abdominal sacrocolpopexy. Okay, and having cough and breathlessness, most probably suspected of pulmonary embolism. Okay, so this becomes your situation. Okay, this patient, she is 66 years old, operated for abdominal sacrocolpopexy for vault prolapse. Okay. So this becomes your background, and she was for discharge today, but she has suddenly developed breathlessness and cough. So this points you to the diagnosis. Okay, so this patient has, it will become your background. So on assessment, she is having tachycardia, hypotension, her high oxygen saturation is also falling, but her temperature is normal. Okay, so most probably diagnosis here is my diagnosis here will be suspected pulmonary embolism. See here, there is no other diagnosis, no other infective pathology because temperature is normal. Okay, now she has suddenly developed breathlessness day 3, so hemorrhage is also less likely, correct? And only she is not having any pain or something, only breathlessness and cough. So here you can point to the diagnosis of pulmonary embolism. So now how you are going to do? What will be your recommendation? So first I will go to the patient and introduce myself to her. Then I will start her on oxygen because her oxygen saturation is falling, correct? So I will start her on oxygen. Then I will assess for airway, breathing and circulation. Okay. Then after initial resuscitation, I will go through her new charts, whether they are deteriorating. I will go through her operative notes also to see whether the surgery was prolonged. Are there any risk factors for a thromboembolism? Like whether her surgery was prolonged, there was a major blood loss was there or not. Okay, then I will also see for in the history. I will if she is in the condition to give the history, I will ask her history regarding any, what you will ask, whether she is passing urine, whether she is passing her motions well, whether she is eating and moving. Okay, so to see whether she is well hydrated and whether she is moving or not. Okay, then you are going to see for any risk factors for thromboembolism like high BMI, any history of diabetes, hypertension, any family history of any blood clots and any drug history. Okay, so these are the things you are going to, any history of smoking. So these are the things you are going to ask for her, any increased risk of thromboembolism. Then you will also see in her drug chart that she was receiving any thromboprophylaxis. Okay, so these are the points that you are going to see for in her history. Then coming to management plan, now you will give order her urgent chest x-ray and ECG. Okay, and if the chest x-ray is abnormal, you will arrange for urgent CTPA within 1 hour. Okay, CT pulmonary angiogram within 1 hour. Okay, if the chest x-ray becomes abnormal. In the meantime, you will start her on low molecular weight heparin, and you will also send her basic blood investigation before starting her on heparin, like full blood count, urea electrolytes and LFTs and clotting studies. Okay, and next thing what you are going to do is you will involve your consultant. You will inform your consultant. You will inform on-call consultant. First, you will inform on-call consultant. Then you will inform the consultant who has performed this surgery. You will involve anesthetist and intensivist. You will shift this patient to the HDU, okay, or ICU, okay, depending upon the anesthetist suggestion or intensivist suggestion, and you will shift her. And if it is a pulmonary embolism is diagnosed on the CTPA, then you will do the management according to the intensivist and anesthetist management. Okay, you will go with that management. Now in the post this incidence in the clinical governance wise, because it is a pulmonary embolism, it requires incident form, correct? So you will debrief her and her family. You will do that incident form. You will file an incident form. You will perform the duty of candor. And here, because you have not done the surgery, this reflective practice e-folio will not apply to this thing. Okay. e-portfolio and reflective practice will apply where you have performed that surgery. Okay, if there is some problem with your management, otherwise this will not apply here. Okay, so clear regarding the first case?
Yes, doctor. Yes.
Okay, so now regarding the next patient. So now how you are going to do it in the S-bar is, she is a 29 years case of laparoscopic sterilization 3 years back. Okay, most probably a case of either internal bleeding or port site hematoma. Okay, background is, yes, she has undergone lap sterilization 3 hours back. Now she is having severe pain at the main port site. Assessment, pulse and blood pressure is normal, temperature is normal. Only thing is there is swelling at the port site with oozing is there. So my differential diagnosis here will be either it is a internal bleeding, okay, any vascular injury while at entry site, or it is a port hematoma, port site hematoma. Okay, so for this patient, first I will go to this patient. She is having severe pain, so I will offer her analgesia. Okay, now whenever you are telling any drugs, you have to tell the dosage. Okay, so in that low molecular weight heparin also, I will adjust the dose according to her weight. Okay, and I will give therapeutic low molecular weight heparin dose for her weight, adjusted according to her weight. Here also you have to tell regarding injectable analgesia or oral analgesia, depending whether she is taking orally or not. Okay, and you can offer either diclofenac or you can offer paracetamol. Okay, then after that, after giving her analgesia, now you will go through her operative notes. You will take a targeted history, like if there is any history of previous surgery. In the operative notes, you will see for any difficult entry, any history of adhesions inside. Difficult entry is very important in this point. Okay, and any history of adhesions, and also any difficulty during the surgery. Now, next thing what you're going to do is, you will, in the history, you will also ask regarding any bleeding disorders, any family history of bleeding disorders, okay, or any drug history. Then after that, you are going to examine her, so see for confirm her vitals. Then you are going to do her per-abdominal examination to see for any guarding rigidity, any distension, okay, to see for any collection. Then you are going to examine that port site also. So still if there is oozing is there and how much is the swelling. And then what you're going to do is, you're going to do bedside ultrasound. You're going to do full blood count, okay, and coagulation studies for her. And now if any internal collection is ruled out and if there is any hematoma is there, then you will inform your consultant and you will drain that hematoma under local anesthesia, secure any bleeder if there are present. Got it? And
Yes,
if internal
yes.
bleeding, yes. See here, most probable diagnosis, because her vitals are stable, that means internal bleeding is very less likely, correct? So here the most probable diagnosis is port site hematoma, but then you have to give in your differential diagnosis that you are going to rule out internal bleeding by doing bedside ultrasound, okay, and doing the full blood count and this thing, okay, clear? Now
Yes,
regarding the third patient, in the S-bar format, she is a day 4 post abdominal hysterectomy and BSO, okay, and having fever and right loin pain. So most probably she is a case of ureteric injury, okay. In the background, 48 years, had PH BSO for endometriosis 4 days back. In the assessment, her pulse and blood pressure, they are normal. Temperature is somewhat raised, okay. And in the recommendations now, first, so always I will go to the patient. Now here she is not having any major complaints, only fever. So you and some pain. So you will see whether she has received antipyretics and analgesics. Then you will, now in her case, you can take her detailed history. She is not emergency case. Yes, she mostly is a case of any internal organ injury. Okay, but she is not unstable. So See, she is not emergency. So here you can take detailed history for her. So in that case, you have to ask her regarding the post-operative recovery and any complaints, like whether she is having pain since when, fever since when, any vomiting. Okay, does she pass motion? Does she eating well? How whether she is passing, whether catheter is still there or she has passed urine. Then what is the amount and color of that urine if she has passed, or if the catheter is there, you have to see for the output and color. Okay, now after that you have to do some investigations for her. Like first you will be doing routine ultrasound and x-ray. So because here your differential will be either ureteric injury, most commonly it is a ureteric injury, or bowel injury, or bladder injury. Okay, so the common will be the ureteric injury. And then here you are going through the operative notes to see if there are any adhesions, if there was difficult, any hemostasis was difficult, any whether they have dissected the ureters or not. Okay, so for that you are going to see her operative notes. Also you are going to ask her regarding any history of previous surgeries. Okay, now in the investigations you are going to do her ultrasound, x-ray, full blood count, urea electrolytes, and urine examination and culture also, because it might be just simple UTI also. Okay, simple urinary tract infection also, we don't know. Correct? So we have to do urine analysis also and urine culture. Now you are going to inform your on-call consultant, this patient, and then you will going to inform your consultant, and you will arrange for her, if there is no major things are found on ultrasound and x-ray, then you are going to arrange for CT urogram for her. Okay. So because CT urogram is the investigation of choice for ureteric injuries. So here you are going to do CT urogram for her, and if any ureteric injury is identified, then you are going to consult the urologist, urosurgeon, and operator consultant, and you are going to plan for her repair, and it will be a return to the theatre. Correct? So there is conservative management is not possible for ureteric injury. You have to repair it, so it will be a return to the theatre, and the repair of that injury will be her definitive management. Okay, and here all the again all the points of clinical governance will come, like debriefing, duty of candor, and incident reporting will come. Okay, and if you have done that surgery, then all the reflective practice and e-portfolio will come. Okay.
And the documentation also, na?
Yes, yes,
Debrief.
documentation will also come. Yes, yes, documentation will also come. Okay. Yeah. Okay. So now the last thing is the last patient. See, Nesma, here the diagnosis of perforation, I think, see here, this patient, now we will go to this case also, case wise we will go, and then I will tell you exactly what is the problem here is. See, this patient, she is a S bar wise, this is a surgically terminated pregnancy, 2 hours back, 19 years old girl, and now she is having excessive bleeding and severe pain. Assessment wise, she is having bradycardia and hypotension. Remember here, this bradycardia is very important. Okay, she is having bradycardia plus hypotension, not tachycardia. Okay, so it is, yes, who has, very good, Manga Devi, yes, it is a arpiosis. Okay, most probably it is arpiosis. Yes, perforation can be there, but see, this bradycardia will occur at the time of perforation, not after that. So this bradycardia is mostly because of this vasovagal. Okay, whenever you are when the cervix is dilated, because of that vasovagal attack, it will be because of that severe pain. Cervix dilatation will give you severe pain, and because of that, you will get that vasovagal and you will get bradycardia plus hypotension. Okay. So yes, your again your recommendation will be, yes, I will go to the patient and first I will start resuscitation. Okay, now here you are not we don't know whether she is in the case of you will introduce her or not, but I will start her resuscitation by IV fluids, and I will give her painkillers. Then I will quickly review her notes for the indication of the TOP. Okay, and also see for any difficulty, whether it was ultrasound guided or not, what was her blood group. Okay, whether she is a Jehovah's Witness or not, that was very important point that you remember. Okay, whether she is a Jehovah's Witness or not. And here my diagnosis will be retained products of conception or perforation. Yes, perforation will be your differential diagnosis, but it is a rare thing, okay, with this bradycardia. Now, how you are going to confirm it? So you are going to do you are going to first inform your consultant. You are going to do a bedside ultrasound and bedside full blood count and clotting studies. Okay. So here, a bedside ultrasound, you will find if there are any retained products. Okay. So if there are any retained products, you are going to shift her to the theater and remove these retained products. Now see, this removal of retained products in any accidental emergency or any wards is not recommended. Okay, it is better to take her to the theater urgently and do it under anesthesia. Okay, because if you are again going to dilate this service and removing this product, then again she may again go in vasovagal. So better to shift her urgently to the theater and do her repeat evacuation. Okay, got
Okay.
it? Yes. So clear for this post-operative round?
Thank you, doctor. Thank you so much.
Yeah. Okay. So see, this is the exactly what you are going to, this is a generalized format how you are going to do it in any post-operative round, or for that matter for labor ward prioritization also. Okay. So this is the general pro forma. So you are going to give the summary in S-bar format first. Okay. Then you are going to go to the patient and introduce yourself. Then first offer analgesia or immediate resuscitation whenever, whatever it's suitable in that condition. Take a targeted history, review the new charts and operative notes. Now the targeted history, if the patient is in the condition to give you that history. Okay. Always mention MDT as I told you. Okay. Then always divide the management in clinical and clinical governance part, and this clinical governance part include, as I told you, so it will yes, documentation is there in each and every case. Okay, so okay, clear?
Yes, clear.
Thank you, Dr.
Okay.
Excuse me, Doctor.
Yes,
Dr.
sir.
Mrudula. The
Yes, sir.
last case, the perforation. You explained that how to manage the written product of conception. So, do you think that we can explain also the perforation, that how to manage?
Yeah. Now see, as I told you here, the most probable diagnosis is written products. Okay. Yes, perforation. If you get time, then you can explain. Okay. So if anything, like if on ultrasound you are not going to find out any this written products, then most probably the diagnosis will be perforation. Then in that case also it will be a return to the theater and doing the laparoscopy. Okay. And you have to see whether it requires repair or not, or any other organs are injured or not. Correct?
Yeah. Okay. Okay.
Yes.
Thank you.
Yeah. Yeah. Okay. Okay. Clear? Yes. So now who will be doing the next patient? Yes, anyone for the next patient?
Hello, can I do
Sunita.
doctor?
Sunita. Okay, you have not done yesterday, no? You have not done yesterday, no?
No,
Okay.
no,
Okay.
no.
You can do, no problem. Yeah. 1 minute, I will give you this. Yes. So I will start your 2 minutes. You can tell me whenever you want to go to the next slide, okay?
Okay, doctor. Next.
Yes. So here I'm going to, this is my last slide, okay? Then I have, there are questions. Questions will be started.
Okay, doctor.
Okay. Yes, I will start after the 2 minutes are over. Okay.
Okay. Hello. You'll be asking questions. No?
Yes, your time is up. Okay, you can start.
Okay.
Yes, you can
Hello.
start. Yeah.
This is a structured discussion, right?
Yes. Yes, it is a structured discussion. You can start.
You'll be asking me the questions or should I proceed?
See, for any structured discussion, my dear, you have to start that I'm Dr. So and so. I'm an exam
Okay, okay,
candidate
okay.
for the discussion.
Okay, 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 sir.
Yeah.
Okay, I'm Dr. Sunita. I'm ready for the structured discussion.
Okay, doctor. So as you have read the scenario, what is your differential diagnosis?
My differential diagnosis would be first one gastroenteritis, second one maybe acute appendicitis, third
I'm
one
not able
maybe
to hear you,
ovarian
dear.
cyst.
Hello, Dr. Sunita. Can you please talk loudly? I'm not able to hear you properly. Yeah.
Yeah, one
Yes.
second.
Yeah.
Hello.
Yeah. Yeah. It's
Hello.
okay now. Yeah.
Can you
It's
hear me
okay.
now?
Yes. Yes. Yeah.
My first differential diagnosis would be gastroenteritis. Second
Hmm.
one would be appendicitis. Third
Hmm.
one would be my ovarian torsion or something. These three would be my differential diagnosis. And because it's in the reproductive age, could be a pregnancy related, obstetric related, could be also possible.
Okay. Okay.
Hello.
So yes. So how you're going to assess this patient initially and
Initially,
investigate her also? And investigate what will be your initial investigation after assessing her. So both.
okay, initially, if the patient is stable, I would like to gather the history from depending upon how is the pain, any history of, I mean, because it's already given not specific, I would ask her when was the last periods, is the period regular, is she up to date with her smears, and was she on any contraception? Coming to her obstetric history, is she in if she was she pregnant, I would ask her like any pregnancies, then is she in a relationship, any history of discharge or any history of sexually transmitted infection, if at all this is in relationship. Then I would ask her if there's any medical condition, comorbidities like hypertension, diabetes, if she has any allergies, has she undergone any surgeries or surgical comorbidities. I would like to ask her blood group and any restrictions for blood transfusion, and would also inquire about her support and her lifestyle habits like smoking, after signposting about smoking, drinking, or any drug abuse. Mm, I would ask her about all these things. And coming to the examination assessment,
Sunita, Dr.
I would
Sunita,
like.
your voice is still not clear. People are messaging that you are not audible. Can you please put on your headphones or something like that?
Yeah. Just a second.
Yeah.
Am I audible now? Hello?
Yeah. Now you are very clear. Okay. Okay.
Okay. Then after history, like I would also like examine her with the consent in the presence of chaperone. I would look for general health like her pulse, pulse BP and weight height ratio, and check her temperature per abdomen, if there is any guarding rigidity or any lump, I could feel the tenderness or any collections of fluid, I would. And also I would do I would also send her the some investigations like urine pregnancy test, urine routine and microscopy, and also look for her from down below if there is any infection or discharge, would send her for swab. And I would do an ultrasound to see what could be the cause. This is the basic investigations I would do.
Okay. So yes, these are the findings, examination and initial investigations findings that you have got. Kindly go through it. So I will go for the next question. Once you finish, tell me.
Hello.
Yes, should I go to the question? Over?
Yeah, you can go to the question.
So yes, so this is your question. What is next management plan for her now?
Coming to the diagnosis ultrasound, maybe it looks like the dermoid cyst. Maybe we would work up for pre-app evaluation, like a basic full blood count, and
It
thing,
has
and
been
we
done.
would inform her. We would sensitively inform her about the diagnosis of dermoid cyst to the patient, and then we would do a pre-op workup and we'd do a poster for the operation for the dermoid cyst removal. And I would
Okay.
also explain about and that's it, management, coming to our management. And
Okay.
also in the management we would tell her there are possibility of complications sometimes when operating for the dermoid cyst, uh, like there are the injuries to the surrounding structures, or sometimes the ovary. That time we may have to salvage the ovary. We would tell all the pros and cons. That's it.
Okay. Okay. So yes, this is your next slide. Once you go through it, I will go for the next question.
Okay, doctor.
Okay.
Okay.
So what will be your next management?
Next, our management will be under a multidisciplinary team. I would involve the consultant and
the local region, I mean, oncologist, and I would tell her that because like sensitively explain her about the diagnosis of disc germinoma, then and possibility of like I would also ask her like about her again reconfirm her about her fertility aspect, then maybe tell her about the options of like because of the removal of the ovaries at times the other options like but alternative options of the fertility, or if she would go complete the family at the earliest and go for the removal of the thing, or other options of fertility like surrogacy, oocyte donation, or adoption. And I don't know, I'm really getting stuck.
Okay. Okay, so this is my actually last question. Okay, 30 seconds are remaining. You want to add anything or should we go to the feedback?
Feedback.
Okay, so finish your station. I will go to the feedback.
Thank you for the time.
Okay, thank you, doctor.
Thank
Yes. So first of all, Sunita, yes. Always, as I told you, don't ignore the first slide. Okay, this is a structured discussion. So just now the time is up. So this is a structured discussion. You should not ask anything whether it is a structured discussion or not. It is you are not supposed to ask anything to the examiner. Okay. So this slide is for you to read. Okay. So you have to see for the domains. And this domain reading is very important. Just don't ignore this first part, first page, or any domain page for that matter. You have to see whether it is a structured discussion or whether it is a simulated patient task. Okay, it is always, always, always important. Okay, then you have to see for the domains also. See, in structured discussion, if this information gathering is there, that means you have to start from history and examination. Okay, if this is information gathering is not there, then you can skip the history. So always see for the domains. I think yesterday Jyoti also told regarding this. So you have to see whether this information gathering is there in the domains or not. Okay. So you have to always start with history. Yes, you started with history. That was a good thing. Okay. So you have to start with the history whenever any initial management or assessment is asked. Okay. Now, then you have to read each and everything. So see, it is a see here in each thing, it is only 2 weeks history of worsening abdominal pain, right? So it is a recent onset. It is a 2 weeks history and it is a recent onset increased means large ovarian solid cyst. Why you limit your diagnosis to the only dermoid cyst? Why not germ cell tumor? Like now I will come to the differential diagnosis, but how you can diagnose without any tumor markers that it is a dermoid cyst? Correct?
yes, doctor.
Young girl, nulliparous, to only 2 weeks history of such a big mass, and she's having these pains. So that means it can be a germ cell tumor, okay? And always in reproductive age group, ovarian tumor or any ovarian mass, always keep the diagnosis of that germ cell tumor in mind. And these patients are increasing now, germ cell tumors. It is appearing in every RCOG codes, okay? So this germ cell tumor, it is a very important topic, very important topic. You just can't ignore this topic, okay? So you have to know everything regarding this topic. Now, coming to the first question, what is your initial differential diagnosis? Okay. So yes, differential diagnosis, what you were told, it was correct. Yes, it can be either, yes, you have started from gastroenteritis. Okay, I can agree with the gastroenteritis also. Appendicitis, yes, I can agree with that also. Okay, but now one thing goes against this appendicitis is she is not having any fever. Okay, no tachycardia. Okay, so it goes against that appendicitis also. Now another thing you have to keep in mind is, yes, ovarian cyst accident. Okay, So either it is a torsion or rupture. Okay, so that you have to keep in mind and you have to tell that you told that is ovarian torsion. But always remember this word. It is any ovarian cyst accident. Okay, so it represents both either torsion or rupture.
Okay.
And then as she is in
Dr.
reproductive age,
Mrudula, we will
yes,
say first the gynecological causes or first the non-gynecological causes. How we will start?
no problem. You can tell anything. No problem that you have to tell
And we
gynecological
will
causes.
decide like distribute. We can say like this. I will see any gynecological cause like ectopic pregnancy. She is in the reproductive
Yes,
age and could be
yes.
ovarian torsion.
Yeah, yes, you can start with that thing. That will also gives a good impression that you have started with. It can be ovarian cyst accident. It can be this thing that ectopic pregnancy. Okay, so these are our that is gynecological and PID. Correct?
PID. Yes,
Yeah.
yes.
Yes. So these three
Acute.
things comes under our gynec diagnosis, and other diagnosis will be, yes, it can be appendicitis, it can be gastroenteritis. Okay, it can be any obstruction also. Correct? Intestinal obstruction or this thing. Correct? So these will come under the differential diagnosis. Now, the next thing is how you are going to assess her initially and what initial investigation you would like to do. So here it starts from the history. So yes, now she is having this pain. You are going to give her analgesia. Now remember this thing: analgesia, antiemetics. You will see whether she has received or not. Okay, and then you will take a history from hers that since when this pain is there. Okay, whether it is it was started 2 weeks back only and it was very severe since 2 weeks, or it has increased in intensity recently. Okay, any severe vomitings. Now she is having this vomiting, so nature of this vomiting. Okay, whether she is continuously vomiting or not. Okay, any urinary burning, any constipation, any fainting attacks. Correct. So this will be her present illness and negative history. Now, next thing will be you have to ask her menstrual history, ask her regarding the LMPs. Now, where the smears come in these patients? She is just 18 years, correct? Smears will start at 25 years. So, don't put yourself in difficulty. Okay?
Okay.
So 20
Okay.
smear will
Okay.
start from 25. Please always, whenever you tell regarding the smear, please once note her age. Okay. So here smears will not come. Now, in the menstrual history, you have to ask for last menstrual period and regarding the regularity of the menstrual periods. Then you have to ask whether she is sexually active or not. Okay, if sexually active, any history of sexually transmitted infection, like any history of vaginal discharge, foul smelling vaginal discharge, you have to ask. Then you have to ask her regarding the multiple partners history also. Then and also whether she has been screened for any STIs previously. Then past medical surgical history, any contraception she is using. Okay, and then other history, past medical surgical history, family history, BMI, and smoking, drinking and drug habits. Okay, then you have to examine her. In that you are going to do her, already they have given some, but yes, you have to ask again. You have to recheck the pulse, temperature, blood pressure and respiratory rate. Then you are going to see for her per abdominal examination. There it has been also given that tenderness is there, abdomen is distended, but no guarding rigidity is there. So you will see again, reconfirm those findings. See, there is no this thing that you can reconfirm this finding, you can tell that. So I would like to reconfirm these findings. Okay, then you are going to do per vaginal examination if she is sexually active, per speculum and per vaginal examination if she is sexually active. And next thing is you have to do per rectal examination. Okay, now here one more interesting I will tell you that because she's having this tender distended abdomen. Okay, so just it can be a primary amenorrhea with imperforate hymen also. Correct. So we don't know all these things, so we have to ask for this LMP, and also is very important, just not for ectopic pregnancy. Correct. Hmm? Now, what investigations you are going to do initially is full blood count, urine they have already done, but still urine, midstream urine, you are going to do her pregnancy test, and in ultrasound be specific transvaginal ultrasound if she is sexually active. Okay, otherwise transabdominal ultrasound. So clear for this initial assessment? Now you have got these findings that she is having some tenderness in the right iliac fossa. On examination, she is having this firm, mobile, and smooth right adnexal mass. Rectum is empty. Okay. Then blood count doesn't show anything specific. Hemoglobin is normal, platelets normal, WBC count is also normal. Pregnancy test is negative. Urine examination is normal. On ultrasound, uterus is also normal, left ovary is normal, endometrium is thin. Okay, and it is a 10 by 13 centimeter right adnexal mass. It is a complex cyst, correct? Cystic and solid component. That means it is a complex, large ovarian cyst, and there is no free fluid. Okay, so it is a complex cyst. Anywhere complex cyst in the younger woman, it wants, so what is in the next management plan? So it wants further investigation with tumor markers, correct? For to rule out any dermoid cyst also, you have to do this tumor markers. So you have to do serum LDH, you have to do alpha fetoprotein, you have to do beta SCG. Got it? Yes, these three tumor markers. Any young woman with ovarian cyst, you have to do these three tumor markers. Okay. Now, once you do these tumor markers and you will find, and you have found out that she is having this large complex cyst. Okay. So if the tumor markers are elevated, then you have to suspect it as a germ cell tumor. You are going to send her to the multidisciplinary team. Okay. Whenever you are suspecting germ cell tumor, you are not going to operate her directly. Okay. You are going to send her to the multidisciplinary team. Okay. And if they recommend any investigations like CT, MRI, or any other investigations, you are going to do those things, and then you are going to do her staging laparotomy. See, staging laparotomy for germ cell tumor is different. Okay. And for ovarian cancer, staging laparotomy is different. Okay. So here you are not going to involve other ovary. You are not going to do biopsy for other ovary also. Okay. So in this thing, what you are going to do here is midline vertical incision. You are going to remove this ovary and tube. You are going to remove her. You are going to take peritoneal and omental biopsies and lymph node assessment. That is what you are going to do in this. Okay. It will be a fertility preserving staging laparotomy. In young women with a germ cell tumor, they don't require any contralateral ovary removal or anything like that. Okay, once you find out that another ovary is healthy. So, but it will be after MDT discussion. Okay. Now, if the tumor markers are not elevated and if this cyst suggests of dermoid cyst, then you are going to plan her cystectomy, ovarian cystectomy. And if you find any torsion is there, you are going to do her cystectomy either by open method or by laparoscopic method, depending upon after informing your consultant and depending upon his opinion. His or her opinion, you are going to do either cystectomy open or laparoscopically. Okay. Because it is a big cyst, if it is a dermoid cyst, okay, if the tumor markers are normal, because that condition is that will also comes under her differential diagnosis now. Okay, it can be dermoid cyst, it can be GCT. If tumor markers are normal, then it might be a dermoid cyst. You have to do a cystectomy, whether it is an open or laparoscopy, depending upon your consultant's experience and his opinion. Okay, and you are going to send it for histopathology. And you will tell her that sometimes ovarian removal might be also necessary, and you will counsel her regarding that. Now, once and because it is such a large tumor, there are chances that it might be a borderline ovarian tumor also. Okay, if it is not a germ cell tumor. Okay. Now, once you do this, now see, after that, this next slide is. This is LDH is elevated. Staging laparotomy revealed that it is a dysgerminoma with positive peritoneal cytology without spread to any other organs. Correct? So this comes under 1C. Here staging comes as 1C dysgerminoma. Stage 1C dysgerminoma, that you have to tell. Okay. So stage 1C dysgerminoma. So what is your further management? You are going to explain her the diagnosis. Okay, you're going to explain her the diagnosis in a very sensitive manner. Okay, you're going to tell her that the survival rates with this surgery and further chemotherapy, survival rates are around 90%. Okay, and future fertility is also very well preserved. You have to give her her outcome regarding her fertility also. So with 1 ovary, fertility is also well preserved. She can get pregnant. Only thing she needs frequent follow-ups. Okay, she need very extensive follow-up for at least 10 years. Okay, and she needs chemotherapy. So chemotherapy, she requires BEP. It becomes 1C. She requires BEP, that is bleomycin, etoposide, and cisplatin. Chemotherapy she will require. You have to tell her regarding the cycle frequency of this BEP. It is not required for you to tell all these things, but you can just tell regarding this chemotherapy and what drugs you are going to use, and for her extensive follow-up and her fertility preservation. Okay. In the staging
So,
of
Dr. Mrudula, we will involve the
Okay.
MDT team in her care,
previously
oncologist.
only you will involve. Yes, yes, MDT oncology, and it will be operated at oncologist. It is not she will not be operated at you. You are not going to operate her. If it is simple
Yeah,
cyst or dermoid cyst, you are going to operate her. Otherwise, she will be operated in the cancer center,
yes,
not cancer unit. Also, she will be operated in the cancer center once it is confirmed.
okay.
When the doubt is of germ cell tumor, once the tumor marker are raised and it shows that it is a complex cyst, so it means she is going to operate it in the cancer center after the MDT OPD. Okay?
Okay, doctor.
Yeah. And if you remember the follow-up, you can tell the follow-up, and if you remember the side effects of chemotherapy, you can tell the side effects of chemotherapy also. Okay? But she requires extensive follow for at least 10 years, that you have to tell. Okay, so every 15 days for first year. Okay, for first 6 months, then every monthly for next 6 months, then every 2 months for
And,
second
and
year.
Dr. Mrudula, we will
Yes.
also explain that after the completed her family, she required the THPSO.
Why? It is not for germ cell tumor. It is for borderline tumors.
Oh, yes, borderline tumor.
Yes, it is not for germ cell tumors. After this thing, staging this thing in and everything is required for borderline tumors. It is not for germ cell tumors. Okay, yes, but follow up for 10 years for to see any recurrence. Okay, or any relapse. Got it?
Yes.
Yeah.
Okay, doctor.
Yes. So remember, this germ cell is very important topic. You have to do it, and it is such a small topic. You will finish it within half an hour, but then you have to read it because it is very specific. Okay. Yeah.
Okay, thank you, doctor.
Yes. Yes. Who will be doing next? Hello. Nobody wants to do next?
Can I do, ma'am?
Yes, yes, you can do. Sure. 1 minute. I will give you your. This is your station. Just tell me. I will start your 2 minutes. Just tell me whenever you want to go to the next.
Okay, next, ma'am.
Yeah. This is the last slide.
Should I start, ma'am?
No, I will tell you once your 2 minutes are finished. Okay.
Okay.
Yes, your time is up. You can start.
Hello, I'm Vijay Lakshmi, candidate for the exam, and I'm ready for the structured discussion.
Dear, this is not structured discussion. This is SPT.
Oh, I'm so sorry, ma'am. SPT is what, ma'am? I thought it is structured discussion. Okay,
SPT is
sorry.
simulated patient task. SPT is simulated patient task. Okay.
I'm sorry.
Yeah, it is a role player.
Okay.
Yeah,
Hello,
start.
I'm Dr. Vijay Lakshmi, the doctor in the high-risk pregnancy clinic today. Can I know your name and age, please?
Hello, doctor. I'm Lucy Angels and I'm 31.
And how can I address you?
Lucy will be fine, doctor.
Okay. Lucy, I understand that you had undergone a radical trachelectomy 2 years back, and now you have come for pre-pregnancy counseling. Is it right?
I'm
Hello?
not able to hear.
Not able to hear?
I can't hear you. Vijay Lakshmi.
You can't
Am
hear
I
me, ma'am?
audible?
Yes, you
Hello.
are audible. You are audible.
Vijay Lakshmi. Yeah, I'm not able to hear you, dear. Yeah, right
Should
now
I?
it's okay. Yeah, right now it's okay. Right
Right
now
now
it's
it's
okay.
okay.
Start again. No problem. Start again.
Okay.
Start again.
Okay. Should I?
It is breaking. Yeah.
Should I start
Yes.
from again?
Yes, start now. No problem. I will start your timer.
Okay. I'm Dr. Vijay Lakshmi, the doctor in the high-risk pregnancy clinic today. Can I know your name and age, please?
Hello, doctor. I'm Lucy Angels and I'm 31.
And how can I address you?
Lucy will be fine, doctor.
Hello, Lucy. So I understand that you had undergone a radical trachelectomy 2 years back, and now you have come for a pre-pregnancy counseling. Is it right?
Yeah. Yes, doctor. Yes,
So,
yes, doctor.
so is there anything specific you want to know? Any specific concern?
Doctor, actually, yes, because it was a very devastating thing for me to diagnosed as a cancer and that undergone this surgery. But yes, doctor, at the time of surgery, doctor told me that yes, you can become pregnant. And so we took back for this 2 years, and now I think I want the baby. So I think now I am ready for the pregnancy, emotionally also, mentally also. So I thought I should meet you now.
I'm sorry, Lucy, you had to undergo such a lot of
Regarding counseling.
hello, you had to undergo such a lot of trauma when you were diagnosed with cancer, and I'm glad that you have come over it and now you're emotionally stable to go ahead with pregnancy, and we are here to help you with all possible treatment. Okay. So hello, Lucy, is it okay if I ask you a few
Thank you, doctor.
questions? Hello, is it Lucy, is it okay if I ask you a few questions and then examine you in presence
Your
of a
voice is
chaperone?
breaking, dear. Yeah, your voice is very breaking very much.
Uh, Ma'am, should I put the headphone? Hello?
Actually, it's breaking.
Hello, is it
Vijayalakshmi.
better? Is it better?
Others can hear her clearly, or is it a problem with my connection? Hello?
Hello?
Others can hear her properly?
Yeah, ma'am,
Voice.
we can hear properly. Actually, your voice is.
My voice is breaking?
Yeah, ma'am. Yeah, ma'am.
Now it is.
Okay,
Now I can
actually
hear
it's
you
raining
also.
here. Okay, okay, okay. Go on, go on.
Okay. So uh, I'm glad that you have overcome your episode of your difficult time, and now you're willing, emotionally settled to start with your pregnancies. Angel, so is it okay if I ask you a few questions before and examine you in presence of a chaperone, and then we can decide the management options which is best suited for you?
Yeah.
Okay, so
Okay, doctor.
okay, so Lucy, when did you have your last cycles?
Uh, I had my periods, I think 10 days back, doctor.
10 days back. And
Right
are they
now.
regular? And is there any problem with your cycles?
No, no, doctor. Periods are regular.
Any history of postcoital or intermenstrual bleeding?
No, doctor.
And Lucy, have you ever been pregnant before?
No, doctor.
And are you seeing your GP for any other medical illness?
No, apart from this cancer surgery, I was fit and fine always, doctor.
Okay. And besides this radical trachelectomy, have you undergone any other surgery on your tummy or down below?
No, no, doctor.
Any family history of concern you would like to tell me, like history of any blood clots in the family or any other problem, any history of cancers in your family?
No, no, doctor. Nothing.
And are you how is your partner, Lucy? Is he supportive?
Yeah, yeah. He's very much supportive, doctor.
And have you ever felt down, depressed or low in your previous 4 weeks?
No, no.
And Lucy, can I ask you a few personal questions?
Sure, doctor.
Do you take alcohol, Lucy?
No.
And do you smoke?
Everything. Actually,
Do
previously I
you
used
take,
to, doctor.
okay, so you have stopped smoking now?
Hello.
Have you stopped smoking now? Hello?
Hello.
Hello?
Yes, yes. I have stopped smoking and alcohol. Yes, I have stopped. Can you hear?
Yes, I can hear you, ma'am. There's a voice break in between. Are you are you taking any drugs for recreation?
Me?
Hello?
Hello.
Do you take
Can
any
you hear
drugs
me?
for recreation?
Can you hear me?
Yes, I can hear you. Now I can hear you. Beach mein there was a break. Hello? Hello? Dr. Mrudula, can you hear me? Hello? Hello? Hello, should I continue? Hello.
Just wait, I think she will come back.
Okay. Thank you.
Hello.
Hello? Hello?
Dr. Mrudula, she's offline.
He said she
Yes,
is trying to connect.
Hello, can you hear me? Am I audible now?
yes, Dr.
Yes,
Mrudula
yes,
is
you are.
audible.
Yeah, just 1 minute. I will come to my screen once because it has gone, okay, from me. 1 minute. Okay, can you hear? Okay. Are you able to see the screen and hear me also?
Yes, yes, ma'am.
Yes,
Okay.
doctor.
Yeah. Okay. So Vijayalakshmi, Dr. Vijayalakshmi, are you there?
Yes, I'm here.
Okay. So I will start your 5.5 minutes again. Okay. You can
I'm
start. Yeah.
okay.
You want to do it again?
Yes, because where did I leave? I think I'll do it
You have
again, ma'am.
completed the history. You were almost completed the history.
The
You have
history.
come to the
Yeah.
personal
Okay.
history, correct?
Okay. Yeah. Family history I had taken, and I had taken the psychological history and social
Yeah.
history,
Yeah.
alcohol and drug intake. Okay.
Yes. Almost history part you have completed. Okay.
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 So
So yes,
Lucy,
you can start.
so
Yeah.
Lucy, do you have any allergies to any drugs?
No, doctor.
And what are you using for your contraception?
Doctor, I'm using pills.
Okay. And what is your height to weight ratio?
It is 22.
Okay. And Lucy, after your trachelectomy was done, have you followed up with your cervicals for your cervical screening?
Yes, doctor. Actually, screening means I was in the constant follow-up with my cancer oncology doctor, and they were
Yes.
doing my MRIs and all this regularly. And just now I have made them 1 month back, and they told me to go ahead with the pregnancy. That's why I'm here, doctor.
Okay, that's wonderful. Okay, so Lucy, can I examine you in presence of a chaperone while my nurse takes your BP pulse and your height to weight ratio?
Yeah, sure, doctor.
Okay, so Lucy, now coming to the counseling which you have come for, pre-pregnancy counseling, what specific concern do you have?
Yeah, doctor, means how much safe to undergo the pregnancy now, and what will be the problems that can arise because of my cancer surgery? All this I want to know.
Okay. So, Lucy, one is the effect of pregnancy on your radical trachelectomy, and the other is the effect of radical trachelectomy on pregnancy. So, as such, the treatment which you have undergone for cancer cervix will not in majority of the cases be affected if you try pregnancy, as you have already been screened by the oncology people, and they have given you a head go to for pregnancy. Okay, so
Yes, doctor.
as much as you're concerned about what effect it will have on pregnancy, so there are basically three effects which might occur since you are having your regular cycle, and there is no pain during your cycles. So cervical stenosis, that is the tightening of the cervix due to scar tissue formation, is ruled out in your case. The next could be there, since the cervix, the neck of the womb is not there, there are chances of you having a miscarriage in your second in your after your fourth month. And for that we will be putting a stitch around your cervix, so that you don't go into that situation. The third would be that you might go into preterm labor, that is you might go into labor before time, and thus the baby might be born premature and might need certain resuscitation and might need admission in the NICU, that is the special baby care unit. And also there can be sometimes you can rupture your membranes earlier earlier to term, and again in that condition also you might need admission and expectant treatment if everything is all right, and sometimes you might need to be delivered earlier. Are you following me, Lucy?
Yes, doctor. So, do you think is it safe to undergo pregnancy, doctor? And can I conceive naturally?
See, most of the people can conceive normally who are having regular cycles, because that rules out that the closure of the neck of the womb because of scar tissue, like I told you earlier. And the only problem is that you might go into labor earlier, for which we will be putting a cervical stitch. It would be done laparoscopically, and many a times it is also done during trachelectomy. I would like to go through your notes and just check out on that whether it has been done at that point of time or not. Otherwise, we can do a laparoscopic stitch around the neck of the womb, so that you don't go into preterm labor and mid-trimester abortions. Okay, Lucy?
Okay. Yes, doctor.
So,
And
is there anything else?
any precautions I need to take?
Lucy, you should just take care that you don't get any infections, whether it is vaginal or any urinary tract infections, because they also predispose to preterm rupture of membrane and preterm labor. Okay. And
Yeah.
anything else you would like to know?
Yes, doctor. So I can now straight away go for pregnancy. So no other tests are required to be done right now. Correct, doctor?
Uh, Yes, I think your oncology department has already given a head go to it. But if the stitch, like I told you, the cervical stitch has not been applied, for that we would like to apply it before you try pregnancy.
Okay. Okay, doctor. So thank you. Thank you very much for this information. Yeah, your time is also up, Dr. Vijayalakshmi.
Okay, thank you, thank you, Lucy, for your time.
Okay. Okay. So first of all, sorry for all this disturbance. It is raining here, so I have completely shifted my device to other room and started another connection. Okay. So regarding this station, Vijayalakshmi, the attempt was good. Okay. The history, I think you forgot asking regarding the cervical cancer surgery and everything in the first instance. Okay, and you remembered it afterwards because almost you have finished the history in the first instance, correct? When we
Yes.
have started the station. Okay, then
Yes.
yes, then you recollected that. Yeah, that is a good thing. Okay, so whenever, like, see, it is a high risk pregnancy, correct? And it is, yes, it is after cervical cancer. So always offer your empathy to the patient. I'm very sorry. I feel very sorry after hearing what you have undergone through. I know it must be a very difficult condition for you, but very good thing that you have recovered of all these things and now you are ready for pregnancy. Okay.
Ma'am, I said that, I think.
Yeah, you said that, only thing you were fumbling. Okay.
Yes.
Yeah.
Because it was for the first time I was saying such
Yeah,
things.
yeah, correct. Okay. So yes, how to tell, that's what I'm telling. Okay. And then yes, you have to offer the empathy that you did, but only thing in better words. And the next thing in the history, yes, other history you took very well, my dear. Otherwise, no problem. Only thing in antenatal history, always ask regarding the blood group and always ask regarding whether she is having any concerns regarding blood transfusion or any Jehovah's Witness. Okay. So always it's better to ask. Okay. Then
Okay.
you have to ask because she has undergone such a major surgery. Okay,
Hmm.
so you have to ask how was your recovery afterwards. Did you require to take any other treatments for your cancer cervix, any other like chemotherapy or radiotherapy? Okay. Hmm?
Okay.
And
Okay.
yes, and how was your recovery and how, when was your last follow up, that you have to ask. Okay, when was your last follow up with your cancer doctor? And remember, don't use jargons. Okay, like postpartum bleeding, intermenstrual bleeding, resuscitation. So don't use this jargon. So do you have any bleeding problem in between your periods? Okay, that you can ask. Hmm? So yes, right now she is telling that she is on contraception and she is having regular periods, correct? So you have to ask whenever anyone is for pre-pregnancy counseling, you have to ask since when you have been married, okay? And how is the support at your home? Are you taking folic acid? Are you immunized for rubella?
Okay.
Huh? Okay. So these are the basic things that you have to ask in any pre-pregnancy counseling. And her specific that she told you that I have been follow up with my oncology and they have given green signal to go for pregnancy, correct? So now once you came to know that yes, now she is ready for pregnancy, so ask her to start taking folic acid. Okay, and it's a very good thing, Lucy, that you have come for pre-pregnancy counseling so that you will know exactly what to expect in your pregnancy. Okay, so encourage her about that. Okay, and appreciate. Then next thing, now when see in the trachelectomy patients, sometimes they may require fertility treatment. Okay, almost 50% will require fertility treatment. Now there is a good talk for this trachelectomy 2017 talk, and this talk is this your station. Okay, it is your station. Okay,
Okay.
so if you read, and you don't have to read all the talk. Okay, the table, there is a big table. Big means okay, there is a table, they have given complete antenatal management of this. Okay, trachelectomy, radical trachelectomy, and some things, that is what are the complications involved with it. Okay, now always remember trachelectomy has a stitch. They have always a permanent stitch. Trachelectomy means they have given the stitch. Now you don't have to see whether they have given it or not. Okay.
Acha, okay. Okay.
So there will be always insertion of a permanent stitch at the isthmus because cervix
Okay.
they have removed. Okay, so there will be always a permanent station. They will require some treatment for, they may require some treatment for fertility. So yes, Lucy, you can try for natural conception, but we will also refer you to the fertility clinic. Okay, so they may guide you better regarding whether you can become pregnant naturally or you require any other assistance. Okay. So that is the thing. Now, always MDT, never in high risk pregnancy, any maternal medicine, you have to, your pregnancy will be monitored in the consultant led unit, a special doctor specialized in the cancer, like your oncology doctors, okay, and the midwife and the GP. So it will be a consultant led care and who are specialized in dealing with such pregnancies. Okay. So your antenatal care, once you become pregnant, your antenatal care will be in that unit, okay, in the MDT. So that is the first point. In any maternal medicine, you have to tell that yes, your care will be a shared care in the MDT. Okay. Then next thing, what you have to do, you have to tell regarding all the basic things like would you told what is the effect of radical trachelectomy on pregnancy and effect of pregnancy on radical trachelectomy. So yes, pregnancy is not known to any increase the incidence of any relapse or recurrence of cervical cancer. Okay, so it will, pregnancy will not have any effect on that. But yes, because of radical trachelectomy, she is at risk of miscarriages, most probably second trimester miscarriages, preterm labor and premature rupture of membrane. So you have to tell her in her words that there is increased risk of abortions or miscarriage, also increased risk of your water bag being ruptured, water bag around the baby being ruptured, that is prematurely, and your baby may delivered prematurely. Okay. So these are the things that you have to tell her. And yes, and we will take utmost care to prevent that. Okay, we will take utmost care to prevent that. So you have to do some additional thing. We have to do some additional things in your pregnancy, like we have to supplement you with drugs known as progesterone pessaries. Okay, vaginal progesterone she has to prescribe from 12 weeks to 34 weeks to prevent preterm labor. Okay, then yes, screening for UTIs and bacterial vaginosis. Okay, and giving prophylactic antibiotics. Okay, then avoid intercourse after 20 weeks. Avoid intercourse, avoid strenuous exercises, avoid swimming. Okay, because all these are known to cause infections. Okay, all these things you have to avoid. Then otherwise, it will be routine investigations, blood investigations will be there, dating scan will be there, then Down syndrome screening, that is combined screening will be there, anomaly scan will be there, and monitoring of ischemic length. Okay, now cervical length we can't tell here. Okay, so measuring of serial measuring of ischemic length will be done by a specialist ultrasoundologist who is experienced in that. Okay, to see if you are at the risk of preterm labor. Okay. And if any, and steroids, prophylactic steroids will be given after 24 weeks. Okay. So all these things, and her delivery will be by cesarean section, planned cesarean section. It might be a classical or it might be a transverse depending upon the senior obstetrician review. Okay. And postpartum, see, in any maternal medicine, you have to go up to the postpartum. So postpartum, you have to tell, yes, you can breastfeed your baby. You have to follow up in your oncology clinic after your delivery, and you have to follow strict contraception. Okay. Yeah. So this is regarding this radical trachelectomy. So this is the talk is there, and see, these are the things which are very important. This is the table from the talk. Okay. So it is a consultant-led care in the multidisciplinary input, vaginal progesterone 12 weeks to 36 weeks, not 34, it is 36 weeks. Serial fortnightly ischemic scans. Urine culture sensitivity and vaginal cultures. Okay. And consider prophylactic antibiotics at 16 and 24 weeks. Then steroids from 24 weeks of gestation. Avoid unnecessary vaginal examination. Avoid sexual intercourse from 20 weeks. avoid strenuous activities like heavy lifting exercise, okay, and prolonged period of standing in second trimester onwards. So to avoid preterm labor, you have to do all these things. Avoid elective dental work, important it is, okay, to minimize infection. And antibiotics and steroids if PROM occurs, that is preterm PROM occurs. And deliver by cesarean section at around 37 weeks. Okay, so this is regarding this, how you are going to manage your pregnancy in radical trachelectomy. Okay?
Yes, ma'am.
Yeah? Yes,
Yes.
but it was a good attempt because it was a difficult, like it is a less known station. It has, I don't think it has come till now. Okay? But then there is a specific talk on it, so it may appear anytime. Okay?
Yes.
Yeah. Okay, dear. So all are clear. You got some idea regarding structured discussions and all these things?
Yes, Dr. Mrudula, thank you very much.
Yeah, thank you. Okay.
Dr. Mrudula, you will share the recording.
Yeah, I will share the recording. Surely, I will share the recording. Okay.
Thank you very much.
Yeah. See and follow this our Facebook page also and YouTube. Yesterday's recording is also uploaded on this YouTube channel. Okay. I already uploaded this recording on this YouTube. Okay, you can see that. And yes, we are conducting the course. Okay, because we don't have any Telegram group, open Telegram group. It's not possible for us right now. So we are doing the course for 4 months and only it is limited to 12 candidates only. Okay.
Okay, but so it will just yeah, we need no.
Dr. Mrudula, how much the course fee?
See, you can just contact us, any of us on this, me or Dr. Jyoti on this number. See, these numbers are there. You can take screenshot. You can contact any of us. Okay. And we will definitely let you know. Okay.
Okay, thank you.
Because there is no hemoglobin
okay.
report.
Yeah.
And
Clear? Any doubts? Any question?
no, this doesn't
Yeah,
suggest
thank you.
hemoglobinopathy, but why
Thank you,
the
ma'am.
is so one has to find out what is the
Bye.
root cause. I don't think so.